Good afternoon, everyone. Thank you so much for joining us for today's CMS Measures Management System information session, the Malnutrition Care Score from Idea to CMS Quality Measure. My name is Aya Gunny, and I work for Battelle in support of MMS. This webinar is just one aspect of MMS education and outreach, and so I invite you to visit the MMS Hub website to learn more about MMS and how to get involved in quality measurement. We can go to the next slide. So throughout today's presentation, I highly encourage you to submit questions using the Q&A feature, which you're going to find near the bottom of your screen. We'll address questions during the live Q&A at the end of the presentation, and then following the meeting, we'll share a Q&A summary to answer some of the in-scope questions that we received. Next slide. And so you'll see, just again, if you're not sure what that Q&A function is, you'll see it right down at the bottom when you open it up. You can just type in your question into the box and hit send, and we will get to it through as many questions as we are able to throughout the session. All right, next slide. We can go to the next one. Okay, great. So today we're really excited to welcome the Quality Standards and Interoperability team for the Malnutrition Care Score Measure steward and developer team. So Angela Lago will be presenting today, and some of the other team members you see here will be available to answer questions at the end of the session. We can go to the next slide. And we're also excited to welcome the Malnutrition Quality Improvement Initiative team at Avalere Health. Today, they'll be represented by Shelby Harrington. So thank you all for being with us today. Next slide. Okay, so let's get into today's learning objectives. Over the course of today's webinar, we'll recognize the importance of RDNs, identifying, diagnosing, and treating malnutrition in acute care settings. We'll understand why the MCS is, as an ECQM, is essential to improving malnutrition quality care. We'll evaluate and apply quality improvement strategies for malnutrition care. We'll examine the history of the MCS and successful malnutrition quality improvement stories. And then we'll also understand the steps necessary for successful measure development. And with that, I'm going to turn it over to Angela to get us started. We can go to the next slide.
Okay, thank you, Aya, for that wonderful introduction. We can go to the next slide, please. Okay, so I'm very happy to be with you all here today talking about malnutrition quality and the Malnutrition Care Score. We're going to start out this afternoon by defining exactly what malnutrition is. Malnutrition is a nutritional imbalance between the nutrient your body needs to function and the nutrients it is actually receiving or absorbing. Specifically, when we're looking at protein energy malnutrition, that is the inadequate intake of protein and or calories that results in the loss of fat stores and muscle mass. It can have a negative effect on your health, as you can imagine, and this can occur in individuals who are both underweight and overweight from various causes and over various lengths of time. Nutrition, however, is one of the strongest factors that can be used to reduce the burden of diseases, including and especially malnutrition during an individual's lifetime. Next slide. Okay, so in the acute care setting, malnutrition can be present in all ages, and malnutrition risk can be and often is prevalent in as many as 1 in 3 hospitalized patients. Additionally, a study published in 2018 showed that only 8% of adult hospitalized patients, those would be non-neonatal, non-maternal, were coded for malnutrition, which shows a well-defined gap in care and services. When we're looking at the evidence strongly supports the identification of malnutrition risk can predict certain patient outcomes, things such as length of stay, mortality, and postoperative complications. Evidence also supports having a quality measure, which we're going to talk about today, that incentivizes early malnutrition screening, identification, diagnosis, intervention, and effective transitions of care. Next slide. So there's a lot of information on this slide, and hopefully you all will be able to refer back to it after this presentation. But as you can see, malnutrition has a significant impact on the cost of healthcare in the United States. Data shows a 56% increase in the likelihood of a 30-day readmission for malnourished patients, a 12% increase in the readmission rates for patients with a malnutrition diagnosis, a longer length of stay by 4.3 days, and a higher cost of care while hospitalized by about $10,000 per patient per stay. Additionally, we know that malnourished patients are at an increased risk of complications. We're looking at things such as infections, pressure ulcers, and falls, just to name a few. And malnourished patients are 5 times more likely to experience an in-hospital death when compared to the general hospitalized patient population. We also know that there's strong evidence to support the fact that tackling malnutrition not only improves patient outcomes, but delivers millions in cost savings. So that not only enhances the quality of patient care when we're tackling malnutrition, but it also serves as a business incentives for organizations. Next slide. As credentialed nutrition and dietetic practitioners, so individuals such as registered dietitians and NDTRs, providing evidence-based care while using clinical guidelines to diagnose and treat malnutrition is essential. For the purposes of this presentation today, that care consists of screening, assessment, diagnosis, and care planning. This slide that you can see here shows key recommendations from Aspen. These are guidelines that were published in 2011, emphasizing an approach for care for hospitalized patients, which includes screening, so screening for all hospitalized patients for nutrition risk, conducting a nutrition assessment on all patients who are identified to be at nutrition risk through that nutrition screening, and providing nutrition support interventions for patients that are identified by screening and assessment as being at risk for malnutrition or already being malnourished. This evidence reinforces and demonstrates the importance of evidence-based inpatient care and early nutrition intervention from the nutrition care team. Next slide. Okay, one more slide, please. This leads us to the importance of having a malnutrition quality measure. So the measure we're talking about today is known as the Malnutrition Care Score, and this was formerly called the Global Malnutrition Composite Score. Some of you may be more familiar with that name. The Malnutrition Care Score is an electronic clinical quality measure in the IQR program for eligible hospitals and critical access hospitals. So this measure focuses on the identification, diagnosis, and treatment of malnutrition in acute care settings, which highlights the importance of that interdisciplinary care team within that acute care setting. The measured population consists of adults ages 18 years and older with a length of stay of 24 hours or longer. Next slide. So as you walk through the workflow of malnutrition care for this measure, you'll see that there are some stopping points indicated by the colorful boxes that you can see on the screen. And the first 4 boxes show the 4 key measure observations. This workflow also shows how our care directly powers the quality measure score, which tracks those 4 key measures as measure observations. So measure observation 1, which is the green box, is screening, which first confirms that a malnutrition screening was completed during that hospital stay or a dietitian referral was ordered. Measure observation 2, which is the purple box, is for assessment, nutrition assessment, which then verifies that a dietitian documented a full assessment and diagnosis. The result of that assessment determines whether we continue to move forward in the measure or if we stop there. If that dietitian diagnoses the patient with moderate or severe malnutrition, then the measure continues on to measure observations 3 and 4. Measure observation 3, the brown box, is physician diagnosis, which looks for the physician's formal malnutrition diagnosis in the medical record. And measure observation 4, the blue box, is for care plan, which last but not least checks to see that a nutrition care plan was implemented to treat the diagnosis of malnutrition. So this process can continue on into the discharge planning portion of the patient's care, which is indicated by the red box. But for the purposes of the actual measure, the first 4 boxes are the identified elements of the Malnutrition Care Score measure. Next slide, please. So in order to capture the various components of the score, these are the data elements that need to be identified within your electronic medical record, within the documentation, and mapped to the measure value sets or codes for the measure to be calculated correctly. For example, you would need to identify where the nutrition assessment is completed by the dietitian within the medical record and work with your facility on matching those codes with where the assessment is found, where the result of the assessment is recorded, and where that can be found within the medical record so you can map those things together. You'll see little red crosses on the first 4 items in this list, and those are data elements that are present in other electronic clinical quality measures. So those are already being used. The additional elements below that are unique to this measure. So as we previously mentioned, those unique elements as the malnutrition risk screening or referral, the completed nutrition assessment, a malnutrition diagnosis, and completed care plan, all with a timestamp from that electronic medical record. Next slide. Okay, so for this next portion of the presentation, before we move on to Shelby, I am going to walk through recommended steps for implementing malnutrition QI in your facility. This portion of the presentation is particularly focused on any registered dietitians or NDTRs that are with us today to help you kind of get started in this journey. Next slide. This image shows the general structure of process improvement, something that you can use whenever you're trying to start your own process improvement project. This is one pathway to consider as you implement QI. There are, as you all know, a variety of QI tools and methods out there to choose from. One of the tools that I like to talk about often is performing a gap analysis. So a gap analysis is when you are identifying the current state that you're in compared to the desired or ideal state. You're identifying that gap that exists between the two and then creating an action plan to bridge that gap. as any of you that have tried to do quality improvement work before can attest to, the nature of QI often requires that we pivot and turn with new discoveries. So this pathway does leave room for modifications along the way. And today we won't walk through each of these steps, but I wanted to include this for you to use as framework as you walk through these processes on your own, or start moving forward with your own quality improvement project. Next slide. So continuing on with the gap analysis example, once you have identified the gap or your area of focus for quality improvement work, you really need to create a strategy and structure to guide your process, because you want the time and energy that you're putting in this to be successful. So you need to have some structure. This slide lists questions that I believe would be helpful to you and your team as you get started, and to use at regular intervals along the way. So if you're going to pull a couple of slides out from this presentation, this would probably be a good one to keep handy as you start your quality improvement work. Asking and answering these questions routinely can be vital to your success. So you will want to consider where you are now, who needs to be there with you, what training or education is needed, what needs to be communicated throughout your organization or with your leadership, and how you will achieve that communication, what documentation requirements or electronic medical record changes are needed, what type of data you will need to support your efforts, and then what are the next steps to keep you moving toward one step by step closer to your goal. Next slide. So to dive into this a little further, let's look at a sample implementation timeline and the various phases that you may go through in getting a quality improvement project off the ground and to the sustainability phase. Now, this isn't exactly a timeline by definition, but it does give you kind of an example of phases that you'll move through, but the depth and breadth of your QI project will determine how quickly you move through each of these phases. So I just kept the labeling generic. And this is based off of my prior experience in malnutrition quality improvement, and may serve as a good template for you to use or a checklist as you go along the way. And in each of these phases, you'll want to refer back to those questions on the previous slide that we just discussed to keep you moving forward to the next phase. For example, in phase 1, you will want to start getting the footing together for your project. And some of the tasks that you'll want to include are creating that initial project team. You'll want to map your workflow and perform a gap analysis or some other type of tool or method within quality improvement work or process improvement methods. You'll begin discussing that communication plan, gathering baseline data, possibly discussing various data points of interest. And from personal experience, I encourage you to focus on data from the very beginning and not wait until you're a year or two down the road, as it will be much harder to capture that retrospective data at that point. If you can have some data up front, it's much better for your project overall. So as you move into phase 2, some of the tasks that you'll want to incorporate include maybe expanding the depth and breadth of your project by including external resources, other subject matter experts possibly. It may be necessary to enhance the skills of your nutrition team. Maybe your dietitians or your NDTRs need additional training to help this project be more successful. You would also want to start or continue increasing organization awareness of your initiative by involving more medical providers, possibly more senior team members, and then continue working to optimize your medical record. This will be something you are doing throughout the entirety of your project for that ongoing data collection and care optimization. Moving into phase 3, you will begin or continue having regular meetings with your executive team lead or sponsor. I mean, this can happen much sooner than phase 3. I definitely encourage it to happen. The sooner, the better. But you'll want that to be ongoing throughout the whole time so they know what you're working on and the importance of it. You may need to continue upskilling your team, bringing on additional subject matter experts. So maybe by this point you need an IT analyst, or you may need to be in touch with your electronic medical record vendor or clinical informaticist. Maybe you're finding out that there's different people that you need to bring on board. And then you will continue to conduct the ongoing data extraction and evaluation and maintaining that communication and EMR optimization. So the communication is key because you want your organization to know what you're working on, and you want your dietitians also to be recognized as the experts on that work that's occurring. And then finally, in phase 4, you'll want to work on hardwiring your QI project into your organization so you can reach that sustainability phase. Now, this may be 2 years into your work, this may be 5 years into your work. So you don't want to limit yourself. Like I said, it depends on the depth and breadth of your scope. And then even in this final phase, you'll want to continuously evaluate your workflow. You may need to conduct another gap analysis or some other type of method of QI, and then identify any gaps that exist and continue to create ways to maybe monitor your data in real time, such as a dashboard that's continuously updating so you can see where you are, and then continue reporting out that information at the organization or system level. Next slide. So when it comes to data, I know I've mentioned this a couple of times already, but whether you're in a large organization or a smaller business, most, if not all, companies are going to have key goals that they're working toward. If you don't know what those goals are, I challenge you to make that your first priority. And then consider how you can align your malnutrition quality improvement project to the goals of your organization. It's important to consider and know what your organization's key performance indicators are, so you know how to align with them, what data you may need to show that alignment, and then if you're having a difficult time on determining what data would be appropriate, what are other ways to capture the value that the dietitian and NDTR bring to the patients and the organization. Next slide. So in conclusion, it's important to recognize that implementing the Malnutrition Care Score is an interdisciplinary process. This is not something that a dietitian in a hospital and organization can do alone. This measure's success involves a variety of areas and disciplines. It is designed to be a collaborative measure, and it promotes the credentialed nutrition and dietetics practitioner to get involved and interact within departments that maybe they have previously not interacted with. For example, the clinical nutrition manager or lead dietitian can present and promote the measure by focusing on the patient and improving the quality of care within the organization. They can communicate with hospital executives, IT, and quality departments. The electronic health record companies can support by helping with alignment of data collection and reporting needs. IT and informatics can help identify and collect the data within the EHR as well, and ensure that the systems that you have are able to collect data to meet CMS requirements. And then finally, hospital executives can support and champion the measure, which is why it's so important to have them involved in knowing what's going on as close to the beginning as possible. All right, so now we are going to move into the next portion of the presentation with Shelby. I'll turn it over to you.
Thanks, Angela. If we can go to the next slide. I'm going to go through the history of the MCS. For those of you that have been around for a while, the GMCS is what you might remember, but it has been officially renamed. So for those of you that are interested in the measure development process, you'll learn about how we went developing the measure and some lessons we learned along the way. I'm also going to share a couple of implementation and improvement success stories from hospitals that participated with our learning collaborative and incubated and refined the measure over the years of development. So next slide. MQII, the Malnutrition Quality Improvement Initiative, was founded in 2016 as a partnership between the team at the Academy of Nutrition and Dietetics and their Commission on Dietetic Registration and Avalere Health, with the goal of improving the quality of malnutrition care in the hospital setting. The ultimate vision of this partnership was to create a quality measure for the inpatient quality reporting program for IQR focused on nutrition, knowing that having a measure in a major reporting program is a very powerful tool for driving improvement on a broad scale. As you know, evidenced by the number of people that are on this webinar today, it's a really powerful way to get attention to the role of nutrition in hospital care. So we've recruited hospitals from across the country to participate in a learning collaborative in which MQII provided the tools and the training for how to optimize nutrition care processes. And then the participating hospitals shared their experiences and learned from one another on what worked and what didn't. Concurrently, we were designing the initial draft of the MCS, the initial skeleton of what would become the measure itself, which if you've been through the measure development process, you know that this requires real world data to show that your measure is valid, feasible, reliable, and ultimately that it positively impacts outcomes. In our case, we had a subset of learning collaborative members who very graciously volunteered to share not only their measure data, but also their outcomes data, so that we could show that improving malnutrition care would improve outcomes. And specifically, we showed that increasing rates of improved nutrition care had a significant improvement in readmissions. MQII, as it exists today, hosts resources on our website, malnutritionquality.org, to support hospitals and others in the healthcare ecosystem in understanding the value of the MCS and really the value of nutrition care in general, how to successfully report. And we're also sharing news and resources on developments in the nutrition space, guidance on expanding nutrition care into other care settings outside the hospital. So I encourage you to check out the website. Next slide, please. Measure development is a long process, and our partnership with the Academy goes back more than 12 years to when we first started studying the state of malnutrition care and thinking about strategies to address the gap in quality that we were seeing. We first conceived of this idea of developing a measure back in 2016, and then developed actually 4 separate measures. As many of you know, the MCS in its current state has 4 components. And so we had actually created it as 4 separate measures, but CMS recommended, and rightly so, honestly, that it be merged into a single measure. And so we refined the specifications accordingly. We tested them through the Learning Collaborative. And then we submitted them to the measure contractor at the time that was measuring the MMS system for CMS. And after going through the whole consideration process, which involves submitting the data covering a range of qualifications, as I mentioned, your evidence base justifying the measure concepts, the testing data that shows our measure was reliable, valid, and feasible, we were thrilled to see that the measure was officially proposed and then finalized in 2022 for implementation beginning with the 2024 performance year. We are eagerly awaiting the release of the 2024 data from CMS to see how many hospitals chose to submit the measure in 2024 and what their performance rates looked like. But along the way, we've also had some significant changes in the measure. As you know, the measure originally focused on older adults, age 65 and older, but recognizing that malnutrition is an important condition regardless of age, the measure has been expanded to cover ages 18 and older, which will go into effect with this coming performance year in 2026. And of course, the measure name has been simplified. We went from the Global Malnutrition Composite Score to the Malnutrition Care Score. Next slide, please. And over the years working with hospitals, I hope some of those hospitals are on the call today that participated in MQII, in implementing nutrition care strategies and the improvement processes and using the measure as a tool to drive their improvement strategies. We've learned quite a bit about the key success factors that really are important for both improving malnutrition care quality and in capturing the data needed to demonstrate that you are improving and ultimately report that to CMS. The four foundational components that we've heard over and over again, and we've really seen borne out in the hospitals we work with, are that one, you really need to make sure that you're adapting the documentation and data entry flow in your EHR to the clinical workflow. You don't want the clinical workflow and the documentation workflow to be at odds with one another, and they really need to reinforce and work well together. Two, you need to be creating and actively using quality reports that give closer to real-time insight into performance and not waiting until the end of a performance period. Three, that building an interdisciplinary quality improvement team to address all of the necessary changes that need to be made and sustain those changes and manage the change process is really essential. And then finally, number four, engaging hospital leadership for support. I'm going to share a couple of case studies of hospitals that we have worked with that have had success in implementing the MCS, implementing the processes necessary to demonstrate high quality malnutrition care with the MCS. Just a note here, as you see on the upcoming slides, you may see references to the older specifications of the measure. And the intent here is just to show the process and these hospitals' improvement stories. So make sure that you're working with your EHR vendor and with your IT team to ensure you're using the most up-to-date and correct specifications of the measure for the year you're reporting. Okay, next slide. The first hospital that I want to highlight here, this is a large integrated health system. It had 9 hospitals and growing throughout the measure development process. Their first step was mapping their clinical workflow and their EHR configuration to the steps described in the elements of the MCS. They identified the place in the EHR where care would be delivered, where it would be documented, where that documentation would be stored, who would be performing the care, and how it aligns to the patient journey throughout the hospital stay. This visual representation is really important in identifying all those key components up front so that you can optimize how you make any changes in your EHR. Next slide, please. And what that allowed them to do is visually identify if there was any modifications that need to be made and how they document and how their EHR was set up to make the process more intuitive. So instead of things that may have previously been entered in free text, if it was something that was amenable to creating a drop-down menu or a multi-select option, they modified the entry format. They also verified that the necessary information was showing up in the appropriate place for other care team members. So that, for example, the physician was able to see the dietitian's notes easily, or that the registered dietitian who was conducting an assessment was able to see the nurse's risk screening, and that documentation was in the correct places to make that possible. Next slide, please. The hospital also knew that it was important to track their performance and as close to real time as possible so that they could quickly identify and correct any problems they found or figure out ways to improve their performance. They built performance reports that went beyond just the measure score, but included details like stratifying by age groups and including corresponding outcomes measures like length of stay and readmissions. And this hospital shared that they learned quite a bit through this experience that both helped them to improve their nutrition care, but also helped them really in how they approach other measures and ECQMs in particular. As is common in large health systems that grow by merger and acquisition, different hospitals had different templates and different approaches to charting. And at the time, they also had to create a custom dashboard because this was before the measure had been officially implemented. So Epic hadn't yet built the MCS into their ECQM module. And so they had to build a custom dashboard because they were working with us in the early stages of the measure. And as we mentioned earlier, they learned about how they had to have the right stakeholders involved, going well beyond the nutrition team alone to include other clinical team members, to include quality leaders, data analysts, IT report writers, and regulatory leaders. So if you go to the next slide, please. And this is just an example of some of the different leaders that they had involved in their team. If you go to the next slide. Our second hospital had a similar experience in learning over time that they needed to engage different stakeholders to participate, to support the project. And this evolved over time. Some team members needed to be involved as one-time consults. Some team members needed to be involved on an ongoing basis, and some were intermittent. And they made sure that they included a physician champion as a key leader to champion the effort, as well as nutrition leaders, quality improvement specialists, IT team members, and even revenue cycle leaders. I know for many hospitals, if there are changes in how documentation occurs that could have impact to billing and coding, they need to be involved in that process. So often there's a clinical documentation improvement team, and they live within that revenue cycle department, and they have a role to play in ensuring that documentation is compliant and optimizes data capture for billing and coding processes. So if you go to the next slide. And as you can see here, for each stage of the nutrition care process, how the team mapped their workflow and their data flow in the EHR, and then how it appears in the EHR itself. So here, for example, you can see how for this particular hospital, the clinical nutrition documentation was flagged by the clinical documentation improvement team for the physician to enter a malnutrition diagnosis because the clinical nutrition note had all of the supporting evidence needed. And this is where the physician query was entered. Like, you can add a malnutrition diagnosis here because the patient qualifies. Next slide, please. And here we can see how the nutrition plan of care meets the measure criteria per this documentation map that they created, that there is a care note with a nutrition author that contains nutrition recommendations and interventions, and therefore it satisfies the care plan requirements, and that can be mapped in the back end to the appropriate codes to meet the measure specifications. Next slide, please. And this hospital learned that there is tremendous value in engaging the physicians, the mid-level providers, directly through those clinical departments, including sharing department-level data and comparisons between the providers themselves and the departments. They also provided provider-specific education and tip sheets for documenting the malnutrition diagnosis. They did encounter some barriers along the way that they learned to overcome. This hospital was involved in MQII before the official MCS went live in the IQR program. So they were well positioned to capture and report the measure, but other hospitals in their same system were not. And they realized that not all of their system hospitals had the same documentation process and were not set up in the EHR the same way. There also was not an established relationship between the clinical team that was focused on malnutrition care and the team that was responsible for selecting and submitting ECQMs to CMS. So that was a learning experience for them in connecting some siloed teams together across the health system. So ultimately, again, they emphasized that having a team was critical to their success and having leadership engagement. And so with that, I think we are going to maybe go to questions. Turn it back to someone else.
Wonderful. Thank you all so much. We are at time, so we're going to wrap up. Thank you, everyone, for your questions and engagement in today's webinar. Thank you so much to our presenters and panelists for a wonderful session. We can go to the next slide. So as always, please visit the MMS Hub for upcoming events and opportunities, or reach out to us at mmssupport@battelle.org. The materials for the meeting will be available on the MMS Hub following this meeting and in the coming weeks. Thank you again for attending today's session, and have a wonderful rest of the week.